So welcome everybody to the Birds and BBV Bites. My name's Veronica and I'm going to be your chef for today. And I'm not sure whether you realise, but it's actually Women's Health Week this week. So we're going to do a bite on women's health checks. So before I start, I would like to acknowledge that I'm delivering this session on Whadjuk Noongar Boodja. And I'd like to acknowledge the deep feelings of attachment and relationship of Aboriginal people to their culture, their country and their waterways. And I wish to pay my respects to elders past and present and extend that respect to all Aboriginal people that have joined us today. Yeah, so Women's Health Week this week from the 5th to the 11th of September. And the theme for our Women's Health Week this year is It's All About You. So in this bite, we're going to yarn about cervical cancer prevention. We're going to look at the primary prevention, which is vaccination, and then the secondary prevention, which is our cervical screening program. And we're going to do also have some information on breast self-examination and mammograms. If any of you have heard any of my bites before, I do have a passion for cervical screening. I have a passion for cervixes. I love them. I think they're an amazing part of the body. So if you've heard any of my chats before, it might be a bit of a repeat, but hopefully you'll pick up something new today. So as I said, primary prevention is through the National HPV vaccination program, which is a vaccination that is given to all Year 7 boys and girls. It's called Gardasil. It's now a 9-valent vaccination, which means that it provides protection against 9 types of HPV, which includes 2 high-risk HPV called number 16 and 18. Secondary prevention is through our National Cervical Screening Program, and people are invited to commence cervical screening at the age of 25 and then are offered 5-yearly screening up until the age of 74. Please feel free to, I don't mind if you've got any questions along the way and we can turn it into a bit of a yarn, or if you wanted to put any questions into the chat bar, I'll open that up as well. So, yeah. And then Cherry just asked if Gardasil gives a lifetime cover. Unsure on that answer, Cherry, I guess because we've only got so many years of research around Gardasil, because it's been given now since the sort of 2006 when it came out. So, sorry, phone's ringing. I'll just better put that on silent. Yeah, so, but as far as we know, it does provide good protection up until now for those that did actually have a vaccination back in the 2000s. Of course, who knows, we may need a booster later in life, but I guess we'll find that out. All right, so HPV, what is HPV? Well, HPV is a big family of common viruses, and it affects over 80% of the population, and it is transmitted through sexual activity. So as soon as someone becomes sexually active, the chances are they will possibly come into contact with at least one type of HPV. The good thing about HPV is the body can actually clear this virus in about 1 to 2 years. And it is one of the only viruses that the body can actually clear itself without treatment. So there are some women, however, that actually do hang on to the virus. So we are particularly concerned for anyone who might hang on to a HPV that is a high risk, such as numbers 16 and 18, because they can cause changes to the cells of the cervix. HPV also can cause genital warts. So the Gardasil vaccination also covers the genital wart viruses 9 and 11, and other ones as well, which actually causes 90% of genital warts. So we actually don't see genital warts very much at all anymore because of the Gardasil vaccination, which is absolutely fantastic. So HPV not only can cause cervical cancer, but also other cancers, hence why both girls and boys are offered vaccination. So there are other parts of the body that HPV has been known to cause abnormal cells. Thanks for sending that through, Summer.
No worries.
Okay, so school-based vaccination program, Year 7 students are offered 2 doses in the school year. Families are advised to see their GP, AMS or immunisation clinic if their child misses a dose at school. So current rates of HPV vaccination for Aboriginal girls and boys is around 65 to 75%. So we're still, a bit behind there, and definitely need to, make sure that this young cohort is actually offered vaccination when they come to our Aboriginal medical services as well, because they may have missed their vaccine at school. Okay, so when we talk about secondary prevention, we're talking about the cervical screening test, and it's a simple procedure that checks your cervix for the presence of human papillomavirus. And almost all cases of cervical cancer are actually caused by HPV. So I'm just unmuting Helen. Hey Helen, how are you?
Hi everyone, I'm good. How is everyone going today? Thanks for letting me join.
Oh, no worries, Helen. We're just talking about HPV vaccination and cervical cancer to start with, because it's Women's Health Week.
Fabulous.
Yeah. So as I said, almost all cases of cervical cancer are caused by HPV. So if you're aged 25 to 74, you have a cervix, and you have ever been sexually active with any person of any gender, you need to have a cervical screening test. So the cervix is part of the female reproductive system, and it connects the top of the vagina with the base of the uterus. So you can see there that the cervix actually protrudes into the vagina. It's around 3 centimetres long, feels like the end of your nose. So it's very firm and it's a very tight muscle. When you're pregnant, your pregnancy hormones actually soften the cervix, and in the last trimester of your pregnancy, that cervix will become softer, so that then by the time it comes to delivery, the cervix is very, very soft and squishable, and then it will actually open up. And when they measure the opening for delivery, they're actually talking about the cervix, whether the cervix is 1 centimetre dilated, 2 centimetres dilated, that sort of thing. So that is actually a measurement of how open the cervix is for delivery of the baby. So it really is an amazing part of the reproductive system. This is actually a picture of a cervix. So when you pop a speculum inside the vagina and open it up, you can actually see the cervix through the speculum, and that's a picture of a lovely healthy cervix there. It's usually got a lot of sort of clear cervical mucus coming from it. Sometimes there is some very thick mucus in the cervix as well, depending on where women are in their cycle. So the cells that are taken from the cervix with a brush for a cervical screen, and this is the brush here, actually sweep over that cervix, and then that brush is then popped into some fluid and then rinsed off. And what that's actually doing is that will then go to the lab and they will check that for HPV. So that is the first step, that they actually check for HPV. And if there is HPV in that sample, they have then got the cells already in the sample. They can check the cells under the microscope to see if there's any changes to the cells at all. So it's a two-step process. Firstly, they check for HPV. If there's no HPV, they do not need to take the cells out of here and have a look at them under the microscope, because we know when there is no HPV, then it is very unlikely to have abnormal cells, because HPV is the major cause of abnormal cells on the cervix. So it used to be called the Pap smear test, and in 2017 it was replaced by the cervical screening test. As I mentioned, the Pap test used to look at the cells first and then check for HPV, as we do it the other way around now that we know so much about HPV. We check for HPV first, and if there is HPV, we then look at the cells. Your screening result will tell you whether or not you have a risk of cervical cancer, and a normal result is called low risk. We'll talk a little bit more about that in a later slide. What else is different about the cervical screening test? We know that prior to 2017, Pap tests were done every 2 years. But we know so much more about HPV that most women will only need a cervical screening test every 5 years if their results are normal or, as I said, low risk. Pap smear tests were done from the age of 18. We know now cervical screening tests are done from the age of 25. And women aged 70 to 74 can still be invited to have an exit test or a final test. So those women that are turning 25, in that year, you actually receive a letter from the cervical screening register to invite you to have your first cervical screen. Of course, I think that's something we still need to have a conversation with our young women when they present to our Aboriginal Medical Service, because perhaps their addresses have changed as well, so they may not receive that letter. So it's really important that if you've got females presenting, when they're 24, that we're actually saying that you're going to be due for your first cervical screen when you're 25. Now, the test is actually done in the same way, but we'll talk more about self-collection shortly. So your doctor or nurse or or your healthcare provider, whoever that is, it may be a women's health nurse, it may even be an Aboriginal health practitioner. They take a small sample of cells from your cervix using a swab. It may feel a little uncomfortable, but it should not hurt. And it only really takes a couple of minutes. If your test shows that you do not have HPV, it is safe to wait 5 years, as it usually takes about 10 years or more for HPV to develop into cervical cancer. So it's actually very, very slow growing, the HPV effect on cervical cells, and that's why five-yearly cervical screens are absolutely fine. It also gives the body an opportunity to clear the virus itself if you should have a low risk type. Now we have a real game changer. Self-collection has always been available since 2017, but initially it was only available if you were over 30 and you were more than 2 years overdue. But now, since the 1st of July this year, the cervical screen is available to all women. This resource here is actually on the National Cervical Screening website. I think it's actually really quite good, and it shows eligible women how they can actually take a self-collection. So the self-collection, they use a special swab called a flock swab. And the flock swab is a little bit different to, say, a swab that you would do an MCNS or a wound swab. It's actually got a little bit of a different type of top on it. It's almost like a foam. It's very, very soft. And that is actually, women can do it themselves privately. The thing with self-collection is, at the moment, it's not something that can be done at home. It is something that you would do at your doctor or Aboriginal Medical Service or Women's Health Centre or Sexual Health Clinic. However, you can do it yourself and then hand it to the clinician. So it's popped inside the vagina. And hang on, sorry, I'm just admitting somebody else. Yep, so it's just popped into the vagina, wriggled around, just held in there for a little bit of time, and then it's removed and put back into this package. And then that is handed to your healthcare provider. It's available for all women now, so it's just so good. Oh, sorry, just before I do that, the reason why at the moment they want the self-collection to be still done with the clinician is that there's that opportunity to actually have a yarn about what the results will mean, and also to give the women education around cervical screening. So it's providing that opportunity to touch base face to face. And at the moment, because it's been introduced for all women, this is what's happening. I think perhaps in the future it will be something that we'll be able to do at home and probably take into a pathology or pop in an envelope or something like that. But currently, it still has to be done in the clinic.
Can I just jump in, say something, V?
Yes.
I just wanted to say as well, often this is the sort of thing, like similar to STI checks, that you actually end up going and doing it in the bathroom at your GP. Or at your AMS, so it's not like someone's there watching you.
Oh no!
Yeah.
Oh,
just to make that clear.
Oh yeah. Sorry. No, you don't have to do that right in front of them. That's a very good point. No, you go to the bathroom and you do it privately. That's right. Yeah. So, okay, let's look at what the results will be. So, if there's no HPV on your self-collection, you can return for your screen in 5 years. You will be reminded 3 months before your next test is due, because I don't know about you, but 5 years is a long time to try and remember. So, so if there's no HPV on your self-collection, 5 years. If HPV was found in your self-collection sample, then you'll be asked to go back and see your doctor or nurse, and they will collect another sample that includes your cervical cells. So if there is HPV in your sample, you will need to have a speculum inserted where they will need to use a brush to take the cells and then pop the cells into the solution. Okay, so that's the thing with the self-collection, is we don't get the cells. So therefore, if there is HPV, we need to get the cells. So you'll have to come back and get a cervical screen using a speculum. Okay. If HPV was found in your sample, your body will probably clear it on its own, and it's safe for you to wait for 12 months before you test again. Okay, so some HPVs, as I said, actually, if we leave them alone, the body will more than likely clear them. So some samples may come back as a repeat test in 12 months. So it really does depend on the type of HPV that they've found, whether it's higher risk HPV or lower risk HPV. If the laboratory couldn't get a result from your sample, this doesn't mean that there's something wrong. It just will mean that they actually didn't get a very good sample and they want you to book back in 6 to 12 weeks' time. if you have a high risk HPV and that was found in your sample, it needs extra tests or treatment, and you will be referred to a specialist. So they're all the results that can occur after your cervical screen. Does anybody have any questions about that so far?
I just wanted to check with you, V. So when you get your results back, you'll either get like low risk. Is it like low risk, medium risk, high risk for HPV, or? It
says low risk is a normal result.
Yeah.
Yep.
Hi.
And then, hey.
Sorry, I'm a clinical nurse. So
yes.
Normally what you see on reports is they will list HPV 16, HPV 18 and HPV other.
Yes.
So the way I explain to people is I'll run through that. I'll print off the report and I'll say HPV 16 and 18 are the ones that we're really wanting to look for. And I'll say, and they're not detected, which is really good. But then I'll go to explain HPV other. And I'll just say to them that there's like over 100 types of HPV. And because we're becoming really good with the program we have in Australia, we've keep on seeing other numbers that keep on coming up, and this explains why we've gone from 4 to now 9 in the vaccine. So what's happened is we keep on finding more numbers that seem to be a lot more common. And I just say, so we just list it as HP other, and no, that's not detected, or yes, that's detected. What tends to happen is on a path report, they'll advise you of what needs to happen. So if nothing's detected, then it's like, we'll see you in 5 years, or we need you back in a year to repeat the cervical screen, because we know the body will clear HPV virus most of the time. Yeah. Does that make sense?
Yeah. Thank you so much.
Yeah.
Okay. Yeah. Cool.
It does become a little bit confusing, but I think what's really important to know that if there's no HPV, it'll come back as saying low risk, and so therefore I have had people actually say, oh, does that mean that there is a risk? And I say, no, that's just how the result is actually named. That means that there was no HPV in your sample, so therefore you are low risk for cervical cancer, basically. Yeah.
It's also takes a long time to get to cancer. It's one of the very slow ones. That was very good grammar. Slow growing cancer. So what I've learned is it can take up to 20 years for changes. So it's just to reassure people, you're low risk, and we've moved to 5 years, which is great.
Yeah. Okay, good. Thank you very much for that, Sarah.
Okay.
Right. So when is self-collection not appropriate? So that's for anybody who has symptoms. So if you have any symptoms, which would be something like, bleeding in between your periods, so that's some spotting, any abnormal pain, pain during intercourse, perhaps things that would actually alert a clinician to go, no, I think that at this time we're actually going to offer you a cervical screen where we actually need to take some cells from the cervix. So a self-collection wouldn't be sort of recommended for any women that have any symptoms. And also, if somebody is coming in for like a test because they've had abnormal cells, then a self-collection would not be appropriate either. So if somebody who's had, say, for example, as Sarah mentioned, they've had HPV numbers 16 and 18, and they need to be referred to a specialist for a check called a colposcopy, then those women would require a test using a speculum and taking cells from the cervix. So, so there are times when self-collection is not appropriate. And also anybody that's had any treatment on their cervix for abnormal cells. Okay. So if I've had the HPV vaccine, do I still need to be tested? Yes, so the HPV vaccination will cover you for 80 to 90% of the HPV that causes cervical cancer. However, it won't cover you for all types of HPV, so that's why it's important that we still offer cervical screening to all women aged between 25 to 74. So since the introduction of the cervical screening program in 1991, cervical cancer has actually been halved. So it really has made a huge difference to the rates of cervical cancer in Australia. We do find, though, that over 70% of women who develop cervical cancer in Australia have either never been screened or do not screen regularly. We know that Aboriginal women cannot currently be measured for how many Aboriginal women are actually screened because it's not mandatory on the pathology forms to put whether or not you're Aboriginal or not. There is actually a little tick box there, but a lot of the time it's actually not used. Evidence is available, though, Aboriginal women's participation in cervical screening suggests that they are underscreened, that they are 3 to 4 times at risk of dying of cervical cancer and twice the incidence of cervical cancer. So Aboriginal women, we hope that this self-collection will really increase their participation and really support those women that struggle with the shame and stigma of actually having a cervical screen where they need to have a speculum inserted. So, yeah, so watch this space, I guess. I would love to be able to come back in 12 months' time and actually say what a difference it's made. So.
Yeah, I just we do get a lot of questions when we're getting the swabs, so it is out there, and I think the community, yeah, I think it's a game changer. I think this is really great because I think after working predominantly 5 years in the NT, speculum examinations on an Aboriginal female, not remote. I've never done one, so I think this is amazing. That we've moved into this stage. Yeah.
Oh yeah, absolutely. And I think they've actually that I don't know about research, but I know I've heard some people say in talks that I've been to, if a woman actually knows that there's an issue such as HPV on her self-collection, she's going to be more likely to have a speculum inserted and have the cells taken from the cervix if they know that there's a problem, like having HPV.
Yeah.
So yeah. So
I just think, because speculums they're quite invasive. We're all women, so we've all had our cervical screens in the past and everything. So, I think it'll be really interesting to see the uptake and if we can start getting the numbers for recall and increasing cervical screening in the population will be great. Yeah, I'm excited. Yeah,
me too. Yeah. So in summary, there it is in summary. Both options are accurate and safe, and I think that's really important message as well. There has been, there are people out there that, sort of have their own views on self-collection, but we know that there's been a lot of effort and research put into into HPV in general. We know so much more about HPV. So having a self-collection option is just as accurate and safe as a speculum inserted for checking for HPV. Okay, so I'm happy to share my slides. There's some information and links from the Cancer Council, also from the WA Cervical Cancer Prevention Program, who have some really good resources on their website, and also the National Cancer Screening Register also has resources on their website as well, and there's some resources there for Aboriginal Torres Strait Islander people as well. The Jean Hales Foundation is where you can find information on Women's Health Week, and they've also got a lot of resources, not just on cervical screening, but other women's health checks as well. I'm really sorry I've gone over time, but I just wanted to quickly also you're welcome to go if you want, but I just wanted to talk about breast self-examination, because I think this is a really important part of a women's health check as well. Something that maybe you can actually ask your GP or healthcare provider to do a breast examination on you, or what we're actually encouraging women is actually to get to know their own breasts. So and getting to know what's normal, and then if you know what's normal on your breast, then you're more likely to pick up if something doesn't feel right. So our breasts are made up of glands and ducts, and they're actually fairly lumpy. Some women have very lumpy breasts, particularly at certain times of their menstrual cycle. So it's getting to know your own normal lumps. If you have any issue at all that you're feeling something that you're not sure about, you should always get it checked. So I think if I just go on to my next slide, I'll go back to this one. All right, so so I guess how I sort of talk to women about breast self-examination is it's really important to actually expose your breast as much as you can, and that's either by putting your arm up behind your head like that, so that you're actually exposing the breast. You can do it in the shower. You can do it lying down is really good, because you really get to expose the breast tissue as much as you can by lying down. But sure, you can do it in the shower. Get to know your breast. Use the flattened part of your hand. Okay, and you actually and then you're just sort of feeling over your breast and getting to know what they feel like normally. Okay, you can use a bit of soap on your hand if you're washing yourself, so you feel over your breast, and then also up under your arm as well, bringing your arm down and just feeling if there's anything under the arm as well. And your breast actually extends like a upside down, or like a teardrop. So it literally goes from up here all the way around. Okay, so that's your breast tissue from here as well. So just feeling on the top as well for anything. So if you use the flattened part of your hands, you're actually covering more of the breast tissue than if you're using just the tips of your fingers. So using the flattened part of your hands, and then do the other breast as well. I tend to do my nipples together, because I feel like if I felt something on one side, I'd go to the other side, and if I felt that it was both the same, then that would be normal for me. If I feel something on one side and I don't feel it on the other side, I would be thinking, well, maybe I should go and get that checked. All right, and that goes for anywhere of your breast. If you feel something on one side, go to your other breast in the same place, have a feel. If it feels the same, it could be that it's just your breast tissue. All right, and what I would actually encourage you to do is to maybe recheck that again in a week's time, to make sure maybe it was something to do with your cycle. But if you feel something on one side and not the other side, and you're alarmed by it, then always get it checked. Now, lumps don't always need to feel soft. They can feel hard. They can feel like a grain of sand. They can feel quite different. All right, so anything that doesn't feel right, always get it checked. So anything like new lumps, new lumpiness, changes in the shape of your breast. So actually looking at your breast in the mirror, we usually have one a bit bigger than the other. Okay, if you have an inverted nipple, make sure you can squeeze the inversion out. If an inverted nipple is something new that you don't normally have, always get that checked. It can sometimes be something like a lump behind the nipple, actually pulling the nipple back in. or if you see any dimpling on your breast, like a button on a cushion, you know, that sort of pulling in effect, that could actually mean that there's a lump behind the skin and it's pulling it in. So look for any changes like that. Discharge from the nipple. We shouldn't have any discharge from the nipple unless you're breastfeeding. So discharge from the nipple is actually abnormal unless you're feeding a baby. So always get that checked. Puckering and dimpling I talked about. Any persistent breast pain or itching around the breast or any rashes. Mammograms. When can we have mammograms? We can have mammograms from the age of 50 to 74. However, from the ages of 40 to 50, you're still eligible to have a screening mammogram. So if you're in your 40s and you want to have a screening mammogram, you can actually call up and book yourself in, and that's not a problem at all. They will see you under 50 as well. For those that live in the regions, look out for your breast screening our mammogram bus that comes around, and you know, often they will book, you know, Aboriginal women in sort of in groups, so that they've actually got support from each other when they go for their mammograms. I mean, mammograms are really great. They can actually pick up a lump even before it's even palpable, before you can feel it. All right, so highly recommend mammograms for women once you become 50, and every 2 years is recommended. Okay, and then just to finish up, other women's health checks. Okay, look, our ovaries, there isn't really a screening. There's no real screening test for your ovaries for ovarian cancer. There is a blood test called a CA125 that you can actually request. However, it's got false positives and false negatives. So it's not the be all and end all of screening for ovarian cancer, and probably the best screen would be an ultrasound. So if you have any family history or you're having any pain, you should always see your doctor, particularly pain during intercourse. If you are worried or you would like to discuss that further, please do with your healthcare provider. Bowel screening, we all know, starts from the age of 50. STIs and bloodborne viruses we always bang on about, and I'm sure that you all know that STIs and bloodborne viruses are highly recommended twice a year, routinely, or after you've changed partner, or if you have any symptoms at all, have an STI bloodborne virus check. Also get your skin checked for any lumps and bumps as well, and don't think like dark skin people still can get skin cancer, so always get anything that doesn't look right on your skin checked. Pelvic floor, I'm going to cover pelvic floor, I think, on a separate bite, because I think there's a lot to talk about pelvic floor. You can get your fertility checked at your GP just with some blood tests. They'll check things like your follicle stimulating hormone and all your female hormones such as estrogen and progesterone. Bone density, that is a check for women over the age of 45 and men over the age of 70, so you can have your bones checked for their density. And my final one was just to make sure that everybody's up to date with immunisations as well. Oh, I'm so sorry I had to rush that last bit. Go to your local AMS, GP practice, Women's Health Centre, SHQ, Community Health, and I really wanted to give a shout out to Hepatitis WA in Aberdeen Street in Perth City, if you're in the Perth Metro. They now are running a clinical service for Aboriginal women who may not want to have their women's health check performed at an AMS. So if I thought that was really good to give them a plug as well, because not all women actually do want to go to their AMS for their women's health checks. And ISHA are a women's health service for culturally and linguistically diverse women and people as well. So, and their website has got some really good resources too. Oh, and that's it. That's it from me.
Thanks, Vee. That was awesome.
So I guess thank you for joining me. I'm so sorry that I ran out of time with the breast, but I hope that you took something away from maybe just getting to know your own breasts. And I think that is an area of the body that can sometimes be forgotten. But we all know that breast cancer is out there. If we don't know somebody, most of us do know somebody that's passed away from breast cancer. So really encourage your clients to have their mammograms if they're over 50, and maybe have some resources around breast self-examination available so that you can actually discuss that with women. Yeah. Okay. All right. Well, if there's not any more questions, I'll thank you so much for joining this bite. Thank you to those wonderful health professionals out there that were able to share their expertise with me as well, because I think it's really great. If any of you would like to present a bite, I would love you to get in touch with me, because the more people that we can have on board to present information, the better. This is an opportunity for anyone to be able to share information, and I'd love to get some people from the regions do a bite. So yeah. All right, guys. Thanks very much. We'll see you all soon.
Veronica.
Yeah, I think Joe had a question as well.
Oh, Joe. Oh, Joe. Sorry, Joe.
That's
Sorry.
okay. I
Yeah.
was just waiting for you guys to. No, I'm sorry. Didn't mean to interrupt or anything, but I just wanted to know: are there any culturally specific, so specifically for Aboriginal women, like posters or guides explaining how to take self-collected cervical swabs?
Yeah. So the one that the National Cervical Screening website actually has a really good poster on how to do a self-collection, and you can actually print off the PDF and put that up. Yeah, it's actually quite good. I quite like that one. Yeah.
So it's
Maybe we'll
the
have
national
to
one.
chuck it in the newsletter.
Cool. I might have
Yeah.
I might give it a Google and find out
So-
where that is.
Yeah,
Hi,
yeah. It
Joe.
was
Yeah.
actually, yeah.
Oh, sorry. It is
No,
quite
go.
a good one.
Mm.
But I was, because I've just got my colleague. I've lost Helen. Helen's meant to come back and work in our health promotion team. I still don't have anyone, but I have been thinking about it's tricky for us in government. We can't just upload things, but I would really like to get our local women to maybe do a little thing on Facebook talking about in language, just to explain, because the national ones are very good, but then I think we just need to go to the next step, which get it onto the platforms and have people talking in the local language, just to explain where we're heading and how to do a self-collected test. Yeah, so
Yeah.
I need Helen
That's a
back
good
to
point.
help. Yeah.
Sounds like something the health promotion teams can get onto. I feel like that's a
Mm.
very good project idea.
Yeah.
It's specifically in the regions.
Yeah, I think it would be of really good, because it will get the key message out, and then when they come and see our as clinicians, they've already got a good understanding of what's going on. Yeah, because the national, I have looked at them and I think they're very good, but I think we could just take it to the next level, because English isn't the first language in this country. So yeah.
And I think the WA cervical screening program is actually working on their new Aboriginal Torres Strait Islander resources still. They haven't released them all yet. So
it'd be good. And just on that note, because we did have something come from our team over in Broome Health Promotion, and we did have to change the wording for this incentive because it did have syphilis on it, and had to take the posters down in Halls Creek. We held back on ours. So this is where just giving that feedback to health promotion, saying it's really important, I think, to talk to the people in these really regional remote areas about would that work, and is that going to be maybe too brushing up against, because it still holds a lot of shame, unfortunately, and that's what we've got to.
So which resources were these, Sarah?
It was more just for the incentive for you have a syphilis test,
Oh,
And
yeah, right.
yeah, and it had, we know it probably works, and this is what I'm saying, I've come from Darwin urban, but would work
Yeah.
a bit with remote. And that's a bigger city. Coming over into the valley, I'm also, yeah, it is more kind of harder sometimes to talk about sexual health and certain topics because it is a bit more shame, traditional, and all that. And I think it's just we were mindful, Arnie, and was like, we can't put these posters up because it's got that word syphilis, and then you're handing a t-shirt out, and then it's the two kind of, someone's going, oh, you've had that syphilis test because you've got that t-shirt. So we're just tweaked it and basically said, just get a health check, and then you can have, and then we talk about syphilis in the consult. Do you know what I mean? So it keeps everyone's you know,
it sort of normalizes it, but it also it keeps it like, you know, sneaky veg.
Yeah,
You just,
exactly. It's
yeah.
normalizing things because that's what I say to people in a consult. It's
Yeah.
part of health.
Yeah.
But yeah, sometimes, yeah, we're just navigating. So with the cervical stuff, it would be good to get more kind of specific for the areas, I think. Yeah, that's just my take. I just sit in the clinic waiting for people. Yeah, or trying to find them sometimes. Yeah.
Oh no, that's great. Thanks, Sarah. Joe, I just saw your question. Is self-collection something that can be promoted in recall messages, letters, and phone calls? Well, yeah, absolutely. Like, I don't know whether it is.
I just wanted to ask this because it is a sensitive topic, you know, and I wanted to put it out to the floor, like what are people's thoughts on that? If that is something that's promoted in recall messages, like as an additional note, or is that stepping over the line?
I'll just say from a clinical I definitely think promote it. It's just that tricky thing that Veronica was explaining, that some people aren't going to be eligible for self-collected because of past history from their results. So it's just really getting the wording right, that yes, self-collected's here, but there is, I don't know how you would word that. It isn't for everyone due to past history. So it's just a bit tricky, and I think that would be talking to your teams and people who are a lot smarter than me, the doctors, and that. I don't know.
Something like if practice is sending reminders out to girls for their 25-year-old one, like their first one, to like kind of promote it through there. Or just saying self-collection is available here dependent on symptoms or something like that.
I think you're right. You could definitely target 25 self-collected. And that's good. 25 and
I think well, it's interesting because then we've got older women who've never had a screen. So, you know, they're the ones that perhaps we're even more worried about in a way, because they've actually missed screening for all those years. And if they did have HPV and it was persistent and it was 16 or 18, I mean, the thing is, it is for everybody. And it is a start. So if there was something on the self-collection, they may be more likely to have a speculum inserted. So
you could always because this is my plan, to go through people's files and to find that information before sending out a recall to say you're eligible. So, you know, it's about your clinicians going through a person's medical file going, oh, you know, there's nothing here that they're eligible. So we'll send them that specific recall. So that's about auditing your files. And so you could go that way as well.
And maybe it's I think it's about having that face-to-face yarn with them, isn't it, really? You're providing that opportunity. You're saying that, you know, we can offer a self-collection. But after the yarn, they may say, oh, look, I'd be happy for you to do a speculum. I mean, I don't know.
Veronica,
It's hard to know. Hard to know. Yeah.
Veronica, does on MMEX, we have like a recall system.
Yep.
So if they're put on there, so it's like an opportunity. So if the patient come in and they due for it, you can offer it to them, and they can either say yes or no, or whether they want to do it themselves, do self-swabbing, or someone to do it for them.
Yeah.
So we got a pretty good system here.
Yeah. Okay. But yeah, because the thing is, and this came up, sorry, I know we're still talking, people can leave if they want. But at the ASHM conference, it was also another thing of, you know, do we offer a self-collection for a cervical screen when we're doing a STI check? Because it's another swab. So, you know, you've got a self-obtained low vaginal swab for chlamydia, gonorrhea, you know, hand them another swab that they can do for a cervical screen, make it normal. Yeah, not it just be a women's health pap smear thing, but rather oh, look, while you're there, we can also do a self-collection. I can see Helen nodding there. I think that's got real merit too, like bringing it up and yarning. And it might also be like, oh, we only did that 12 months ago. You don't need this one as well, you know. But just always reminding them, talking to them about it. It's great that you had your cervical screen. It showed no HPV. Don't need another one for 5 years, but we'll be seeing you before then. Blah, blah, blah. You know, and sort of just really included in your in a normal yarn about STIs as well. I mean, there is that fear of, you know, they didn't want HPV to be linked with an STI, but look, let's face it, it's sexually transmitted.
That's right.
That's right. So I've always been taught with when it was speculums. Well, it is still speculums. It's routine. You're there. Chlamydia and gonorrhea swab, and like it's just it goes hand in hand. So yeah.
I think there's a lot of opportunities here to promote self-collected screening. There's a lot of different, now that it's widely available and completely funded for, I think there's those small little sort of interventions and little changes in practice can really boost cervical screening numbers in Aboriginal women. So I'm kind of excited to see what services do. I'd love to hear back on what kind of initiatives you all do, because that would be great. And if you want any help from us, we can help as well. I think that's something I would, my public health hat's on, and I'm thinking like our team, at least, along with the sexual health team, can help and provide any kind of support in making resources. So if you want us to help,
that's great.
Yeah, absolutely. But we would love to hear from you guys, because you guys are the experts in your areas, and you know, and also it'll change, you know, depending on where you live and what community you're in. So you make it work for whatever you feel is best for the community that you work in. But we would love to be able to hear about what actually is working for you and whether or not we can help by, you know, providing any support whatsoever. As Joe said, we've got, he works in the public health team, and so does Summer. I'm on the sexual health team. So please.
Has like 4 graphic designers. So if you even need just graphic design support, that can be done. So let us know.
Yeah.
Veronica, just before we finish, it's got nothing to do with the screening thing, but what I do too with my sexual health when I'm doing the proof of cure bloods, or if I'm doing bloods in them, I'll always ask them if it's okay if I do it like a stock standard colors, just to check for chronic disease. So that's what I've been doing with some of my things. So killing it with one stone sort of thing. So that's what I've been doing with my ones. And that's how we've been picking up some of the younger ones with chronic disease. So
I definitely agree with Tracy. I kind of now go, I'm bleeding this person for syphilis and HIV, and look, their blood sugars have not been monitored for, you know, so you just add it on, because it's
take the opportunity.
They're there, and it's just kind of then getting people linked into then potentially the other teams that they really need to be talking to. So I do the same. I think it's a good opportunity.
And when I do the notes, I just say patient gave verbal consent to do the chronic disease blood. So just put it in there so they know that they give permission.
That's good. No worries. Great conversations, guys.
I love it.
Yeah, I know. I just was going to say, because at the moment, unfortunately, we don't have a school nurse, and it's we're not behind, but the primary, the HPV. I'm wondering if we can really, because they're so linked. It's just like we miss giving the vaccine, and then we know kids have sex a bit younger. They're not got that protection, and then I think it's kind of then coming around and talking to everyone, parents and all that, saying this vaccine is so important because then it does lead on to women's health when we become adults. And I just I just feel like the two of them are married, basically, your Gardasil and your cervical screen. And I'm just at the moment like when we just add on a chronic disease blood test, I'm trying to do as many recalls when I see vaccines, like checking the air when the Gardasil have been missed. Yeah, so I might have a chat to use about how to. Yeah.
Do you do health checks like the 715s?
They do, yeah. We're just
so we've been going into the school and targeting the boys' academy and the girls' academy, or the shooting stars, and that's where we've been catching. I think
unfortunately at the moment we're just running on quite a small team and very transient. So Tracy, you're in DARS, are you? Yeah. Be good. I'm sitting at Fitzroy Crossing, so it'd be good and quite new to just link in, because we're getting everything built in, but because at the moment
that's like you're getting an AMS there soon, aren't you?
What's that? Yeah,
but you're getting an AMS there soon too.
Yeah, but we've got to, I think it's going to operate out of a building until it's built.
That's correct.
I'm very much like, I need something yesterday. Yeah, that's okay. I just think I
happy
need
to
something.
yarn if you want to give me a call. It does.
And just see how you're operating, just so I can. It's good, I think, to share knowledge of what works and what didn't work, and just while we're kind of got positions not filled, unfortunately, because it impacts the community, and that's as a clinician I'm like, no. So
I work in really good with community health and Derby, because I cross-reference our clients only because we're dealing with the same clients. So happy to chat.
Sweet. Okay, I'll give you a call this week.
No worries.
Maybe as well be if we can link Sarah in with Linda Langari or with Hams or something. If there's someone she could talk to there.
Yeah, I've been
linking. Yeerayungi and Halls Creek, there's a really good Aboriginal health worker there, Georgina Yida. She's fantastic.
Georgina
Yida and Halls Creek.
Yeah, I know Georgina. Yep.
She's really deadly. Yeah.
It's just about kind of saying at the moment, it's me and Anne. So we kind of tag team, and I get caught up. So it's finding who your people are that you can lean on a bit.
That's right. And you've got Anne Leonard in.
Yeah, that's who. Too. Yeah,
she's fantastic too. I've worked with Anne before.
She's my boss. She
she's the one that got me roped into sexual health.
Yeah, she's great.
She's fantastic.
So we have some good days and some good banter in the office.
If I can't find anyone in Fitzroy, I just know her.
Oh yeah, definitely. Yeah, cool.
No worries.
It's been great. It's been like a networking.
Yeah, that's good. That's good.
True.
I'm glad.
And Sarah, I'm going to reach out to you because we can promote any of these job vacancies that you have for this new Archers. I'll find out from you where these job listings are found, and I can let HR know so they can promote it, because they do a regular job promotion
on other platforms. Yeah, Erica and Peppy would love that, because that's what I said about sexual health positions. There's a whole, well, you would know from ASHM, the ASHNA, so the Australasian, so there's a whole platform that we just circulate jobs, going, hey, get these out to all your networks. So the more coverage, definitely. Great.
Thank you.
All right.
Thank you.
Thanks, guys.
See ya. That was
great
great.
To see you.
Bye. Thanks for the in-service. Bye.